Alright, this is Sergeant Bykowski with a block of instruction on medical emergencies. In this block of instruction, we'll go over multiple body systems individually that make up our human body and talk about what associated medical problems can arise with them. As you can see, neurology will be one of the body systems, gastrointestinal, endocrine, cardiovascular, respiratory, renal, and associated altered mental status with those. As you know, from not necessarily going to medical calls as a first responder, but having the fire department on scene as we might be investigating our own things. There are very common things. Difficulty breathing is a very common medical problem, as well as diabetes and altered mental status and abdominal pain. All of those things are probably your most common things that you'll be that you hear when you're out on the road. When you're doing your when you arrive on scene, if we are responding as a supplemental first responder, or we get to a scene where the police are called and we are doing our thing, but you're going to tend to somebody first until EMS arrives. Obviously, your first thing that you're going to do is, being a police officer yourself, it's going to be scene safety. So we're going to make sure that the scene is safe so we could start doing taking that medical role, that first responder role. Obviously, if the scene is not safe, then that's something that we're going to have to rectify before we even think about essentially giving care and assessing anybody. But we do our scene size up, making sure the scene is safe, and then you're getting that initial impression of your patient, right? So your initial impression of your patient is just immediately when you walk through the door, figuratively speaking, or literally speaking, and you see that person there. Are they unconscious? Are they conscious? Do they look responsive? Do they look like they're breathing? That's like all your initial stuff. So what you're going to be doing is getting all that, your ABCs fall in your initial assessment, right? And you're going to essentially form your general first impression of your patient. All right, this person looks real sick. This person doesn't look that sick at all, and kind of based off of things there. When we're talking about medical problems and more of a medical call, you're going to be doing, after your initial assessment, your scene size up, all that good stuff that we just talked about, you're going to look to go to obtaining some kind of sample history, which should be familiar. The acronym SAMPLE: signs and symptoms, allergies to medications prescribed, past medical history, last oral intake, and events leading up to. Those are just to get a baseline and a background on our patient. With medical, we kind of ask a lot of questions first, and then we get into our evaluation and our treatments and stuff later, whereas like the opposite side to that is trauma, and that is we get to a call, we do our scene size up initial assessment, and then we do a lot of the hands-on work first and then ask questions later. Medical is just that medical, we're pretty much asking questions first, doing treatment later, unless there's life-threatening issues at hand that we need to do. But after we get our assessment done, our initial assessment, then we'll get the history from our patient, our vital signs, and then we start going through our things. All right, oxygen, or I can assist with aspirin, or I can assist with an EpiPen, or you need this or that. So that's kind of what we do. Each things, a lot of issues have the same signs or symptoms as stated here. So that's why we're kind of taking in everything, the totality of circumstances, what they're saying, what they're exhibiting, the environment around them, and seeing if we can't narrow it down to one, or hopefully one, but one or two possibilities of what they're going through instead of looking at a broad spectrum. If someone says they have difficulty breathing, then obviously, okay, is it cardiac, is it respiratory, is it environmental, did they get stung by a bee and have an allergic reaction, do they have this, do they have that? So that's where you're questioning, that's where sample, OPQRST, those acronyms to help you narrow down what is going on so we can treat them for what they need to be treated for. Altered mental status is something extremely common, I'll say. When I say common, I mean you can get altered mental status from just about anything. Especially some things, the longer things go on and the longer that they're in like this state of acute medical problem, then we're going to have some associated problems. If someone has difficulty breathing and their oxygen saturation is 92, they might be fine, and be alert and responsive in A&O ×4, alert and oriented ×4. However, if they stay untreated and unevaluated and we don't fix the problem, then at some point later on they're going to go into some sort of altered mental status. We're trying to stop that, obviously, in just about all cases, so hopefully we can narrow things down before they get to that point. But there's also things that altered mental status exists immediately, and that's like your opiate overdoses are what we see all the time, right? People shoot up heroin, sniff heroin, and then within seconds to minutes they're completely unconscious, altered. It is what it is. So it can happen at any point, but just know altered mental status pretty much can happen almost with any problem that we have. But again, AVPU is our acronym for that. AVPU is alert to verbal. A is alert, so just someone being alert to, like I said, when you walk into the room. If they notice that you walk into the room, they're alert. If they're alert to verbal stimuli, that means you walked into the room, they didn't turn their attention towards you, they didn't realize that you're in the room until you said, hey, I'm Officer so-and-so. And then they start engaging with you. They're to verbal stimuli. Painful stimuli, both alert and verbal didn't work, so now you go over, there's a couple, you're pinching the earlobes, a sternum rub, things of that nature, that you're painful stimuli, you're trying to elicit a response via pain. So if they don't have that, then they're completely unresponsive. Just a quick and down and dirty way to break it down as easy as possible. Just be alert to any changes. So like I said, you could have someone difficulty breathing with and they're fine, but as time goes on that their level of consciousness deteriorates. So you just got to be aware of that. Altered mental status, like I've already said, can happen in so many circumstances, almost any circumstance, if stuff goes on long enough. But you're pretty much your big ones, especially for us here, is your overdoses, opiate overdoses, or any type of medication ingestion, heart attacks, difficulty breathing, strokes, seizures, fevers if they get hot enough, anything cardiac, your heart's going too fast or going too slow. If I didn't say diabetes, your high blood glucose, low blood glucose, things of that nature. So initially we're going to always do our ABCs, right? Because we want to make sure that we're not missing anything life-threatening, any signs and symptoms of life-threatening behavior. So check our airway, check our breathing, check our circulation to make sure all of those things are within normal limits. And then we can move on to kind of narrowing down with questioning what what avenue we're going to go down, what issue we're going to we believe that is causing all of this. Seizures. Seizures are just high electrical impulses in the brain. There's all different types of seizures. They aren't your typical. Whenever I think of a seizure, I'd imagine anybody else thinks of a seizure, they think of the full body shaking, like the typical thing you see like on TV or something, like foaming at the mouth, full body shaking, stuff like that. That's like a grand mal seizure is what that's called, is the full body thing. But there are so many more types of seizures. There could be absent seizures where people just go, essentially unresponsive for a short period of time, and that could actually be a seizure. There could be tonic seizures, clonic seizures, both tonic-clonic seizures. There could be a bunch of different ones. So you just have to kind of be aware of what is normal, what looks normal, what doesn't look right when you're there. But seizures typically last 1 to 2 minutes, if that. 2-minute seizure would be a long seizure, to be honest with you. So essentially, if someone has a seizure, then we're just gonna, if you're thinking like the full body seizure, as I am, you're just gonna let them do your thing. I remember a long time ago, when I was in medicine, they used to say, when I first started, when I was a teenager, it was, put a bite stick in their mouth so they don't bite their tongue, and try to hold them down to prevent them from hurting themselves. We don't do that. We just let them do their thing, make sure that they don't, start moving around into like a entertainment center where a TV falls on top of them, right? You just let them seize, don't touch them, don't try to stick your fingers in their mouth to try to keep them from biting their tongue. Just make sure that they're safe while they're seizing. We're essentially just going to wait until they stop seizing so that we can start essentially just monitoring them, assessing them, keeping an eye on their ABCs, make sure they're breathing okay. Maybe we have to breathe for them. Things of that nature. So seizures, when someone is having a seizure, paramedics can give medications to stop a seizure. Ativan and Versed is what they carry around here. But like I said, seizures happen and are done and over with in a matter of seconds to minutes. So when I was a paramedic, I've probably given medication for someone actively having a seizure like maybe 2 or 3 times, because typically it happens. So whoever calls 911, and then we get there and it's done with, because it takes us 3, 4, 5 minutes to get there from the time that they had their seizure. So uncommon, but like I said, not much paramedics can do either. If they're actively having that seizure, they could try to give a medication for it. But other than that, doing the same things, monitoring them afterwards. There's febrile seizures, that is in young kids. So when your young kids have super high fevers, it's not so much that they have a super high fever which is causing them to have a seizure, but it's having a extremely high fever, and then they're breaking that fever extremely fast. So like that temperature is dropping extremely fast, they're breaking that fever, and that's what causes the seizure-like activity. So generally, if it is a true febrile seizure with no other complications or anything, they're pretty harmless, right? That's just like the kid's way of getting rid of this fever, this illness, right? Or adults were sick for, I always used to be, I was always told for 3 days, so 1, 2, 3 days you're getting sick, then you are sick for days 4, 5, and 6, and then you're getting away from being sick from like 7, 8, 9. So it takes us almost like 2 weeks to get over being sick. Where kids, they're just breaking that fever. Some of them have febrile seizures, some of them don't, and then they typically feel better afterwards. Like I said, so a true febrile seizure, not really anything to worry about. Don't get me wrong, I am a parent. If my child had a febrile seizure, I'd freak out, and we're going to go to the hospital to get checked out anyway, just in case we're missing something and there could be some other complication involved. I would highly suggest going to the hospital, but there definitely are parents. When I was a paramedic, I'd go, their kid had a febrile seizure. It was not their first time having a seizure, so they decided that they're not going to go to the hospital because they've essentially been there, done that, which as your parent, or as a parent, you have that right to decide how to treat your child, and if they need medical attention. I would always err on the side of caution myself and probably just go. But also that's me with my kids never having a seizure. So I touched upon absent seizures, just like kind of a lapse of consciousness. Their eyes could go like a gaze to one side, like left or right or up or down, and just be kind of locked there for however long the seizure lasts. That is quote unquote normal, but like I said, I mean, kind of uncommon. I've seen it a couple times, but that could be a seizure as well. And as I said, we just monitor our ABCs, rapid transport, and probably do some airway management, some oxygen, things of that nature. Seizures can be caused by, so epilepsy is just like your typical seizure disorder, just kind of you're prone to seizures, and not necessarily something that actually started that or triggered that. Then you can have a seizure due to trauma. You can have associated traumas, head injury specifically, strokes. You can have a seizure from overdoses. You can have a seizure from, so many things. Diabetes, low blood sugar, brain tumors and lesions, things of that nature. So just about anything. And again, treatment as far as EMRs go, ABCs, high flow O2, and rapid transport is pretty much how we're going to handle the seizure-like activity. So heart conditions, there's kind of two big ones that I can think of, and that's, which I know there'll be slides on, that's your heart attack or myocardial infarction and your angina pectoris. But just know that both of those medical problems all kind of stem from narrowing of arteries, which is I can't say arteriosclerosis, and that is essentially just like all the narrowing of your vessels. So that could be from bad eating, fast food, grease, all that stuff, just kind of getting into gumming up your arteries there. Bad smoking, just in general, your arteries can get clogged from so many different issues. There's so many different habits that you have. It's just, even if you are a clean eater and you eat only salad and all sorts of things, just drink water, you don't drink soda, you don't smoke, you don't eat greasy food, your arteries just naturally are going to narrow. There's just going to be some over time, right? But once those arteries narrow completely, that would be a heart attack. It's when there's a complete blockage of your arteries. Or angina is when it narrows so much that only a small amount of blood can get through, which isn't enough blood and oxygen to get to the muscle groups that the heart, in the heart, that it needs to continue to live. So that's what those two things would be. So we'll dive into those a little bit deeper. So like I said, angina pectoris is inadequate blood flow to the heart muscle. So like I said, you have your arteries that are narrowed because of whatever. So typically you'll get angina pectoris from you'll be exerting some sort of energy. So that's like your typical I'm outside shoveling snow and then my crushing chest pain, difficulty breathing, stuff like that. Then you stop what you're doing, you stop whatever it is, shoveling snow or playing a sport or doing whatever, you stop doing it, and then once you stop after a few minutes of rest, your chest pain kind of starts to go away and things like that. That's angina pectoris, right? Because you're under duress, or I'm shoveling, so my body and my heart is saying I need more blood, I need more oxygenated blood to get to my heart, because my heart's working so hard, I need more oxygen to keep up with how hard it's working. But because your blood or your arteries have narrowed, you can only pass so much oxygenated blood, and it's not enough for the demand of the heart. So that's when you start getting all those symptoms of the difficulty breathing, chest pain, nausea, maybe vomiting, things like that. Like I said, angina means it's not a full occlusion of an artery, so once you start to relax, the heart isn't demanding as much oxygen, then it'll start going away. Also, people who know that they have angina pectoris, has been diagnosed, they see a doctor for it, they could be prescribed nitroglycerin tablets. So if you see someone with prescribed nitroglycerin tablets, it's safe to say they have at least angina pectoris, if not a history of a heart attack, right? So what a nitroglycerin tablet is, it's a very small pill that you put under your tongue, and it's a vasodilator, so it just dilates your veins and your arteries, makes them bigger to help pass more oxygen. But that only works for a certain amount of time, and then your arteries will start closing back up to where they normally are. But like I said, they have that chest pain, they're supposed to take that medicine, and it'll make their arteries get bigger so they can pass more oxygenated blood to wherever the heart is demanding it, thus getting rid of that chest pain, getting rid of that difficulty breathing, and all those things. So you could take it, they feel better, but they still have chest pain. You can take it again up to 3 times is typically what is normal. And then I would ask if you're assisting someone taking their nitroglycerin, and you do it once and it's good, but they still have it, so you give it to them again, still have it, give it to them a 3rd time, they still have chest pain, you're supposed to call online med control, supposed to call the emergency room, talk to a doctor about giving any more doses than that. Because vasodilators, obviously, like I said, make your veins and arteries widen, which is going to drop your blood pressure. So we have to make sure that we're not going to make this person pass out. Kind of talked about that already. But like I said, so just to wrap up angina pectoris, we have the signs and symptoms of a heart attack. However, with angina, it typically gets better when at rest and when treated with oxygen, nitroglycerin, things like that. Their chest pain should start going away. So not quite a heart attack. Then we move on to a heart attack. Like I said, myocardial infarction is the correct medical term, and that is a full blockage of your artery. So now at this point, as depicted in the slide, there is no way that any blood is getting through where that clot is to the rest of the heart. And then with that said, the heart tissue and heart muscle after that clot is going to start dying because it's not getting any blood or oxygen to it. So that's where all your signs and symptoms come from, right? Your difficulty breathing, chest pain, nausea, vomiting. That's your heart telling you, I'm not getting any blood, any oxygen, I need help. Also, they have that, so men typically have presentations of that chest pain, could even be back pain, more like a pressure, like an elephant is sitting on their chest. They could have pain that goes into their, usually left arm, into their neck, difficulty breathing, nausea, vomiting, all the things like that. Women are known to have atypical presentations, which just means, those classic signs and symptoms that we just talked about with men, sometimes they don't have that. When I was a paramedic, I had a female who, I went to her house because she had abdominal pain, and she said that she almost felt like it was indigestion, but it was really bad. She didn't have any breathing problems, if I remember correctly. I just remember being a paramedic and kind of knowing about this stuff. I got her kind of like her background, her history, smoker, does not exercise, in her 40s, she smokes, she drinks, so she was kind of like high risk for some sort of cardiac event just based on her on her way of life, on her background. So in knowing that women have atypical presentations, I put her on the heart monitor to take a picture of her heart, and it turned out she was having a giant heart attack. So people aren't always going to show with those typical signs and symptoms. You kind of just have to take the totality of circumstances, take all those things into account to make your decision on what you think it might be. Obviously, if a heart attack goes untreated, or even if you are treating it and you do everything correctly, it just could be their heart could stop beating because like tissue has died, or the heart just couldn't take the stress of not having the oxygen. And obviously, if we have no heartbeat, then we go into that's cardiac arrest. We go into our CPR protocol, right? Backing up. So we're dealing with a heart attack. If we're dealing with a heart attack and the person, we decide, hey, it's, a 50-year-old male, smoker, drinker, overweight, doesn't exercise, family history of cardiac problems, had angina pectoris in the past, just like all these things that are kind of working against them that we think, okay, he's probably having a heart attack. What we can assist with giving baby aspirin, right? So 324 milligrams, I think, is the dose that Med-Control allows, which is, I believe, 4 baby aspirin tabs at 81 milligrams a piece. Add 81 times 4, and then that is how much. I think it's 323 or 324. But we can assist with giving them that. If they have nitroglycerin, we can assist with giving them that. We can give them oxygen, and we need rapid transport to the hospital, obviously, and a paramedic to help. The cool thing about heart attacks, paramedics have that heart monitor, like I said. They can take a picture of your heart and see if there's a issue going on seen on the monitor. If there is, then those monitors can actually transmit. So, once a paramedic sees, hey, this guy's having a heart attack, he can actually send that EKG to the hospital while they're on their way to the hospital. And the hospital can take a look at it, and the doctors will look at it, the cardiologist will look at it and say, yeah, this guy's having a giant, inferior wall heart attack, MI. So, and they can get the ball rolling before the patient even gets to the hospital. They can get the cath lab set up so they can go and remove that clot as fast as possible. So those are some cool things that happen when you have a heart attack. Congestive heart failure, very plainly, as the slide says, is the heart not being able to pump adequately. So you can get congestive heart failure from having a heart attack. Just there's so much damage that your heart isn't able to pump all the blood and all your fluids around your body as well as it did when it before the injury or before the heart attack. So people with like congestive heart failure, you'll see that they'll have their ankles usually will be kind of swollen because they have that pitting edema is what it's called. That edema is fluid just building up at the lowest point of their body because their heart, like I said, isn't able to have that force to pump all the fluid like it normally did. If people are having an exacerbation of congestive heart failure, so like an acute problem with congestive heart failure, usually they'll start building up fluid in their lungs because their heart's unable to pump that fluid around the body and it's resting in the bottom of the lungs. So that's a common thing that happens. It's just that your heart muscles just aren't that strong enough to push all that fluid around anymore. Like I said, it could be caused from heart attack, it could be caused from strokes, it could be caused from a few different things. But typically what you'll see with congestive heart failure is difficulty breathing, a very high respiratory rate, a high pulse rate. The breathing will be shallow typically and rapid because you're trying to get as much air in as possible. Shallow because typically with acute CHF, like I said, you're going to have that buildup of fluid in the lungs. So they're not going to try to take deep breaths because it almost feels like they're drowning because they have fluid in their lungs that it's not allowing air exchange to happen. Moist and gurgling respirations kind of goes on to the fluid in the lungs, sweating, enlarged neck veins. Again, everything's just getting big. It's trying to take in as much as possible to try to regulate itself. So these people, it says put them in the sitting position. These people are not going to want to be, they're going to be sitting straight up, as straight as a board, right? Because they're not going to want, they're trying to get as much air. They feel like they can't get enough air in. So they're going to be sitting up already in most cases. So if they lie down, then that fluid in their lungs is just going to cover more of a surface area. So typically they're not going to lie down. But again, what we're going to do is do our ABCs. We're going to give them high flow oxygen, arrange for rapid transport, and AOS. What paramedics can do. They used to be given, I don't know if they give Lasix anymore, but essentially they give this medication Lasix, it's like a water medication. So they give that, and it starts making the people have to urinate. So it's just getting fluid out of their body that way. These people will likely, if it's bad enough, end up on a CPAP or a BiPAP. It's just essentially like this mask, almost what the BVM looks like. You put the mask over their face, and then you turn on the CPAP, and it's essentially just forcing air into their lungs, and it's like pushing the fluid away from like all the bronchioles and the alveoli sacs and stuff, so the air exchange can't happen. Dyspnea is just a fancy word for difficulty breathing or shortness of breath. Could be because of a multitude of different things. Your heart attack, like we already talked about, your CHF, which we already talked about, your any breathing issues, COPD exacerbation, asthma, allergic reactions. I mean, it could be literally from almost anything. The way we treat it as EMRs is high flow oxygen, rapid transport for people with like asthma. If they have an inhaler, we can assist them with taking their inhaler. But these people, difficulty breathing, we want to get them high flow oxygen. Then we want to kind of reassess them every 5 minutes because it's a critical thing, right? They're a critical patient, so we want to reassess them more often and make sure that our treatments, like our oxygen therapy, is working. Asthma is just kind of spasming of the bronchioles and the bronchi inside of your lungs. Everything is kind of swollen up and spasming, and which is making it difficult for air to be exchanged. That's why you have that wheezing sound, because there's not, air is trying to maneuver throughout the lungs to make that gas exchange, but with all the spasming and the swelling of the bronchi and bronchioles, it makes that whistling sound because there's not as much maneuverability, so to speak. But people who have asthma, who are diagnosed with asthma, may have an inhaler that they use. Again, we can assist them with taking their inhaler, so whatever that means to you. Assist them might mean you could shake it for them and you give it to them and they take it. Maybe you hold it up to their mouth and they press the button. Just kind of do whatever works for you at that moment. Get some. Make sure that the paramedics or the ambulance are en route so they can give some medications to help them get breathing better again and get them to the hospital to definitive care. Strokes, says leading cause of brain injury and disabilities in adults. So like there's two big things about strokes. Strokes, there's two kinds. There's a hemorrhagic stroke, which is essentially an artery in your brain bursts, so you're bleeding into your cranium. That's a hemorrhagic stroke. And then there's an ischemic stroke. An ischemic stroke is a clot that has kind of like your heart when you have the myocardial infarction. That clot is lodged in there. It's a complete occlusion, allowing no blood flow to get past. It's the same thing, but in the brain. So with that said, ischemic strokes are the most common out of the two. Thankfully, ischemic strokes are the most common. Take up about 80% of the strokes, which are good because at least with a clot, as long as they get to the hospital in the appropriate amount of time, they could be given clot busting medication, TPA, to try to dissolve that clot and restore blood flow. With a hemorrhagic stroke, the only way to fix a hemorrhagic stroke is brain surgery, is for a surgeon to go into your cranium, into your brain, and stop the bleeding. So obviously you can see how risky that would be, because we're literally going into someone's skull, into their brain. Hemorrhagic strokes are their mortality rate is very high, as you can imagine by just what I just said. I mean, you're bleeding into your brain, and the only way to stop it is for someone to cut through your skull to get to your brain to try to repair that. Signs and symptoms of strokes are, your most common stuff you're going to see is the slurred speech, the aphasia. So like one side of your body is going to be paralyzed, and one side will be typically normal. Difficulty breathing. If it's bad enough or it goes on long enough, you could have a seizure. So we have this thing called actually I believe the Cincinnati Stroke Scale is in here. And then, yep. So the Cincinnati Pre-Hospital Stroke Scale is what we use as first responders around here to determine if someone's having a stroke or not. And what that 3-prong test is we're looking for facial droop. So you have the person smile, see if, typically, like I said, one side will be paralyzed, so it won't move. So, one side of the face will go up like a smile, and the other side will just stay as is. Arm drift, so you have the person close their eyes, put both of their arms in front of them, straight out, and then you just watch if one drifts away or not. And then abnormal speech, you can usually tell if someone's slurring their speech. But that's what you're looking for. If you have a positive on those 3 things, then it is definitely possible that they're having a stroke and that they need to go to a hospital. Like for someone, we're in Manchester, for someone in this town to be having a stroke or a suspected stroke, we don't want them to go to Manchester Hospital. We want them to go to a stroke center. So that would be like your St. Francis or your Hereford Hospital, because they have neurologists that are working there 24/7, that once you get there, they do a CAT scan to see what kind of stroke you're having, and then, like I said, as long as you're in the window, I think the window's like 4 to 6 hours from onset. If you're having an ischemic stroke, you can get the TPA, which is that clot busting medication, to help dissolve the clot if it's a ischemic stroke. For us EMRs, there's not much anyone can do. It's really a thing that people need to go to the hospital for. Even paramedics can't really do much, So for us, it's ABCs, high-level oxygen, and rapid transport to the hospital. Paramedics can put them on the heart monitor, take a picture of their heart, and give them an IV, and that's pretty much it. They're not even going to give fluids or anything, because they're having all this pressure built up. Typically with strokes, this person's going to have a blood pressure through the roof, so we don't want to put more fluid into their body, creating more blood pressure. They could obviously go unresponsive, just like that's kind of a risk of any bad medical problem. And if they do, again, we're kind of just going off of the signs and symptoms. If they're unconscious, unresponsive, monitor their airway, monitor their breathing, monitor their circulation. If they go into cardiac arrest, we do CPR, but you just got to make sure that you monitor them at all times. Diabetes. Diabetes, essentially, the person can't, their body doesn't make enough blood glucose, or their body makes too much. That's essentially what it is. I'm sorry, insulin, not glucose. So there's type 1, type 2 diabetes, depending on what side they're on. So some people go into that, are prone to going into that hypoglycemia, which is that low blood sugar, where they might need like sugar pills to eat something to keep on always lifting up their blood sugar. And then there's people who need insulin, so they have enough blood sugar in their body, but they don't have enough insulin to break all that glucose down into energy for the body to use. So they might have to bolus themselves insulin, give themselves insulin every time they eat to help break down all that blood glucose. Insulin shock is enough insulin but not enough blood glucose. Your signs and symptoms, that's kind of like the people that don't have enough blood glucose. Hypoglycemia, so like your typical range for blood glucose level in your body is 80 to 100. These people are maybe at like 20, 10. Everyone's different for at what level they start being affected by it, like their mental status and things like that. Pale, moist, cool skin, rapid, weak pulse, so they need some sugar immediately. If you get there and they're, even if they might be a little bit altered, but they're able to carry on a conversation, they just don't know where they are or anything, and we determine, okay, whether we know they have diabetes, or they tell you, and then you check the sugar, or they check their sugar while you're there and it's low. Maybe we watch them drink some orange juice or eat some bread or something to help get some blood glucose in their body, or have some candy bars or something like that. That's like one remedy. The paramedics can come give sugar via IV to help combat the low blood sugar, but all that is a very temporary thing. They need like those complex carbohydrates to keep their blood sugar up. If someone is unconscious, we don't want to give them anything by mouth at that point, right? So glucose tablets, we used to have like the little syrupy glucose tubes. We don't have that stuff anymore. We don't give that stuff. But if someone's unconscious or unresponsive, we don't want to administer anything, because now we're just kind of creating like a choking hazard, or a potential choking hazard. So if they go unconscious, ABCs, high flow oxygen, make sure you get a paramedic and rapid transport to the hospital. Diabetic coma is too much glucose, not enough insulin. Like I said, a normal blood glucose level in someone's body is between 80 and 100 typically. So these people are maybe like 300, 400, 500. So what these people need is insulin, so that the insulin could start breaking down that blood glucose, therefore lowering that level of blood glucose in their body. Those people used to have to stick themselves all the time with needles. Now a lot of people, insulin pumps are pretty common. It's always connected to their body, so like when they're about to eat a meal, they'll bolus themselves a little bit of insulin, so they know that they're going to be putting in food which is going to up their blood glucose, so they bolus themselves some insulin so that the insulin can break down that blood glucose and keep them in a normal range. Those people are going to be your kind of warm, dry skin. Their face is going to look red, almost like they're an alcoholic. They might even have that, depending on how high their blood sugar is, might have some like fruity acetone-like smell to their breath, which might make you think that they're intoxicated, but in reality they actually have a blood glucose of like 700. So that could be something that might throw you off. Paramedics don't carry insulin. That's only something that a doctor will give. So these people need just to get to the hospital to get their blood sugar managed by a doctor. Just This slide just depicts the two different types of diabetic emergencies, the shock and the coma, and the signs and symptoms side by side. It says give diabetic patients sugar by mouth and arrange for rapid transport. As a paramedic, there's been plenty of times where I've gone to someone's house and because maybe they have altered mental status or something, I figure out that they're diabetic, we test their blood sugar, it's low, and then I sit with them, make them a peanut butter and jelly sandwich and sit with them while they eat a sandwich and an orange juice and watch their blood sugar go up. Because people who live with diabetes, it's very hard to control your blood sugar even if you're on top of it and you're doing everything you're supposed to. The common cold can come and wipe out your insulin or your blood glucose and wreak havoc with that. So it's very hard to manage, and these people have been in and out of their hospital as long as they've had diabetes, so they're never really thrilled about having to possibly go to the hospital because they're there for so much. They know they're just going to sit there so they can be monitored and kind of essentially be there for the day, and a waste of a day, so to speak. So these people aren't typically going to be too excited to go to the hospital. Like I said, I've spent many of time sitting in people's living rooms with them while I watch them eat, and we take their blood sugar after they eat, and as long as it's good and we have somebody there that will monitor them for a little bit, like a family or friend, then sometimes we'll have them sign a refusal and they can stay home. But you just kind of have to judge all those circumstances for yourself. You should always insist that they go to the hospital. However, obviously, we can't just force people to do whatever we want them to do. So, abdominal pain. There's so many reasons why you can have abdominal pain. There's you have yards and yards and yards of intestines. You have a lot of different organs in your abdomen. So there's so many possibilities. Pre-hospitally, we don't really treat abdominal pain. If someone's in excruciating pain, like you could give pain meds as a paramedic, but I mean, it's so hard to even tell if they actually have the pain that they're talking about because there's so many things that it could be. So typically abdominal pain, people might have some pain, they might have some diarrhea, vomiting, things of that nature, and we just got to get them to the hospital to make sure that so a doctor can try to diagnose their abdominal pain. So EMRs, it's pretty easy. You have your ABCs, oxygen therapy, and transport to the hospital. The only one thing that I shouldn't say that. So there's a couple things that you'll look for that will say, okay, something definitely is going on here. If you palpate their abdomen and they have a rigid abdomen, hard, then it could be indicative of some internal bleeding and things like that. So you palpate your abdomen right now, it's going to be even if you work out a lot and you have a firm abdomen, it's still going to be kind of squishy when you palpate it. If it feels like a rock and there's abdominal pain, then there could be something going on there. There could be some bleeding. So that is something to look out for. Also, the most, I'd say, severe thing for abdominal pain is a AAA, an abdominal aortic aneurysm. And your aorta is like one of the biggest veins in your body, and it runs right down the center of your body. It goes all the way up from like your pelvis, straight up vertically into your chest, and it dumps right into the heart, like directly into the heart. It's a very big vein, so if you have an aneurysm, which is a weakening of the wall of your vein or your artery, then that could burst. And then if that bursts, then there's going to be bleeding. And like I said, it's one of the biggest veins in your body, so you're not going to last very long if you have if you start bleeding from that. So that's a very serious thing. I believe it's in this slide actually. Yep, AAA. So the aorta becomes weakened, and if it does burst, the only way to fix it, it's a surgical emergency. So if your aneurysm bursts, then a doctor has to go in and repair that. Obviously, that is time consuming to go to a hospital, get into be diagnosed with it, get put into an operating room, get the doctor scrubbed in, and then go into repair. That's obviously kind of time consuming to do that. So, and we're talking about bleeding from a major vessel. We're talking about only having minutes to spare. So as you can see, it's a very serious thing. If it doesn't burst and it's still just an aneurysm, a weakening of the wall, we'll be able to feel, if you put your hand on someone's abdomen, you'll be able to feel pulse there, because that weakening of that wall will kind of, you'll be able to feel that heartbeat every time your pulse goes. So that's like your sign and symptom. Blood pressure, if you take a blood pressure on the left and the right arm, they're going to be vastly different. That's a sign and symptom, or a sign of AAA. And some tearing like abdominal pain. So those people need to get to the hospital. They say that you're not even supposed to, like, don't jostle them. So like hitting speed bumps at 90 miles an hour could tear that aneurysm open, which would be a bad day. So I mean, that's what probably the biggest abdominal injury could be. Again, EMRs, ABCs, high flow oxygen, and rapid transport to the hospital. Kidney disease or kidney failure. So your kidneys aren't working. Like, your kidneys are used to, it's a filtration system essentially, so it helps filter out waste from your body, and you excrete it by urinating, right? So you have all these toxins in the body, that in your bloodstream, that just from everything you're taking in, whether it's alcohol or the food that you eat or anything, you have all this toxins goes into your kidneys filter it out and excrete it by urinating. So if your body can't do that efficiently, then you're going to feel awful. You're going to just generally feel like crap. So what you need to do, people with either kidney failure or partial kidney failure, is they might go on hemodialysis, which essentially you get hooked up to a machine, and it takes the blood out of your body, puts it in the machine, cleans it in the machine, and puts it back into your body, because your kidneys are unable to do it. Very time consuming thing. Hemodialysis typically is like an all-day event, every other day if you're in renal failure. So you're looking at like 8 hours a day, every other day, at a dialysis center getting your blood cleaned for you, because your body can't do it itself. Some people with that go to hemodialysis every other day, they will most likely have a shunt placed in one of their biceps. Well, not in their bicep, but the upper arm where your bicep would be on your humerus. It's essentially just some different plumbing to help. It's a faster way for you to get hooked up to the hemodialysis machine. So just know that there is a thing called a shunt that can be placed in the arm. You can't take a blood pressure in an arm that has a shunt on it, because you can ruin and cause some bleeding in the where the shunt is, and that can only be fixed by a surgical or a surgeon. And that is pretty much it. So that is your medical emergencies